ever.
How annoyed were you when it turned free a couple years ago?
It is what it is. You can't be.
Fair enough.
Was there any talk while you were there that was going to happen?
No, it was
Really?
long after I left. Yeah.
Okay.
All right, we are live.
How annoyed were you when
everybody.
it turned free a couple years ago?
It is what it is. You can't be.
Maggie,
Yeah.
was there,
What was that?
we're hearing the
The YouTube
live.
live stream.
Yeah. Okay. Yeah, I just fixed it.
Okay.
All right, great. So we'll wait a couple minutes before we start, but I just want to introduce our guest today. Our guest is Dr. Malik. She's a urologist at the University of Maryland Medical System, and she specializes in female pelvic medicine and reconstructive surgery. She's board certified in urology, and she attended the New York University Medical School and graduated from the University of Chicago Residency in 2016. She also completed a fellowship in female pelvic medicine and reconstructive surgery at the UT Southwestern Medical Center. She's highly accomplished, and we're so excited to have her. She's also very active on social media and YouTube, and I really recommend you go watch some of her YouTube videos. They're super fun. I recommend the Scrub series. I'll leave a link to her YouTube, Instagram, and Twitter in the chat. Make sure to follow those. She has some great content, and they're very knowledgeable and fun. So without further ado, Dr. Malik, whenever you're ready, you can start.
Sure. Let me just. Nope. Wrong thing. There it is. Okay. You guys see it okay? Okay. So I'm Dr. Malik. Thank you guys so much for having me. I hope you all find this very useful and I can help answer some questions for you afterwards. But I'm going to talk a little bit about my journey to becoming a urologist. And as Magdi mentioned, I am assistant professor of surgery in the Division of Urology at the University of Maryland School of Medicine. I also am a specialist in what's called female pelvic medicine and reconstructive surgery. And I am very active on social media. So a little bit about me. I started, like many of you, in pre-med at the State University of New York at Buffalo. And I kind of always knew I wanted to be a doctor. My mom was a nurse, but I did try to talk myself out of it. I tried to go do an internship at a wholesale distributor of technology goods. And I was quite good at it, but I didn't find it very fulfilling. And I just always thought that medicine was for me. And I'm sure you all are in that situation. And I'm very happy that I went through with it. I don't think I would have done anything differently if I could do it all over again. So I matched at New York, or not matched, I got accepted to the New York University School of Medicine and started there in 2006. And this is a photo from back then, very grainy, but from my white coat ceremony. So it's a pretty exciting time when you start medical school. You get that white coat, you get to be with your parents, and they're so proud of you, right? And you're off to become a doctor. And it's just the most exciting thing. And at least when I went to medical school, and of course the curriculums are always changing, the first 2 years were pretty much read textbooks, study, kind of like an accelerated college degree, right? You're really learning intensely about medicine, physiology, pathophysiology, and anatomy, all those sorts of things. And so we studied hard, we got it done, we enjoyed ourselves, and it was hard, right? You're used to being the smartest in your pre-med class, or one of the smartest, because you are obviously very smart and interested in medicine. So you've been working hard, and you come in and everyone is like that. So once you get there, I would tell you not to ever compare yourself with others. As long as you are doing your best and you are enjoying yourself while doing it, maintaining balance, even in medical school, is super, super important. So then you go to your third and fourth year and you decide, what kind of specialty do you want to specialize in? And I had no idea what I wanted to do. So don't get put off by those people who start next to you and say, I know I want to be an orthopedic surgeon from day one, because it doesn't matter whether you know from day one or on the last day of your third year rotation before you're about to write your application. At the end of the day, what matters is that you've found something that you enjoy and that you want to commit your life to. So when you're considering what specialty you want to do, you want to think about what kind, first of all, do you want to take care of patients regularly, right? There are patient-centered specialties and non-patient-centered specialties. And then do you want to take care of them over many years? Do you want to see them over and over again, or do you want to see them in an acute phase setting? And that you will find when you go on rotations and see what you really enjoy. Do you want to take care of adults or children? And with children come taking care of their parents as well. So those are things to think about. And then once you do your surgery rotation, do you like being in the operating room? Is it something that is enjoyable for you? And it's hard to say really if you will be a good surgeon at that point, right? You just scrub in, you help, you watch, but you're not doing the operating. And sometimes even for me, it got very boring to watch someone else operate because you're not using your hands or doing anything. That doesn't mean that you're not going to be a good surgeon or enjoy yourself in the operating room. That's just the nature of the beast. And then when you do eventually get down to your top 2 or 3 decision points, you might say, what is the most mundane thing you do in that specialty? So for me, I was between urology and ENT or otolaryngology. And I said, okay, urologists change Foleys. That's the consult that we get a lot. That's kind of mundane. And in ENT, they get a lot of trach changes. And that was a decision maker. I did not like this part of the body, but I was totally fine with changing Foleys. And I found it actually enjoyable. I still do. So I think that's a good way to think about it. And then lastly, find your tribe. And I will get to this later again, but it's really important to look at the people who are in that specialty and think if they match your personality, if you would like working with them. Generally speaking, there is a type. I know you'll see lots of memes and jokes about like what kind of people orthopedic surgeons are and what kind of people anesthesiologists are, radiologists, but generally speaking, there is a personality type. And so if you generally like the people you work with, you will be happier. So now these are things that you might say, are you a surgeon if you're not a morning person, if you're klutzy, if you didn't play video games, or you want a family and you're a woman? Well, I will say that I am all 5 of these things and I am a successful surgeon. So none of these apply to you. And people will say, yes, you will meet surgeons who say, I knew I was a morning person, or I'm super efficient in all my movements. And I played tons of video games when I was younger. And I knew that work was going to be the love of my life. And that doesn't matter. That doesn't mean that you have to be like that. I think that I'm very klutzy. I like fall and drop things all the time. I did not play a lot of video games. I am definitely not a morning person, although I've become one by needing to be one. I have a family and I am a woman. So I think that all of these things are, don't listen to the naysayers. If this is something that you want to do, you should do it. And then once you're at the point of doing the rotation on surgery, it's a very difficult rotation because you just don't know what you're supposed to do. There's just not a lot of guidance and you are kind of thrown to the wolves. You like learn to scrub and you learn to do certain things, but it's very different from medicine where you're going to round on your patients, you're going to do X, Y, Z, and everyone tells you like, these are the 10 things you have to do today. In surgery, it's a little bit less structured. And so my tips are always know your patient. So whether you're going to round on that patient or you're going to scrub in on the operating room, know why you're seeing them, what brought them there, what were the symptoms they had, what were the tests they had, how did they find out that they had this particular cancer or this particular problem? What did they try before they got there? So know that's easy. You look in the medical chart and you read it. And then you say, hey, I'm also going to read about this pathology that the patient has. So if it's something like prostate cancer, I'm going to go read, what is the treatment for prostate cancer? How does it get diagnosed? What are the symptoms? So that it will also solidify that knowledge in your brain. And then when you're about to go to the operating room, go prepared. So know the basic steps of the operation. Nowadays, there are so many videos available, like articles online about steps of the operation. You don't need to know every nitty gritty detail, but if you know if you watched a 10-minute video on the surgery, you'll at least know what anatomy you're looking at and what it looks like, because even though Netters does a beautiful job of showing you anatomy, it's different when you're looking at it inside the person. And definitely know your anatomy, because as a first year medical student, you will learn anatomy, and that will be expected that you should know anatomy better than, you're better than anyone, because you just, just learned all the landmarks and all the specific findings during your first year. And believe it or not, there are people who don't actually go and meet the patient they're going to operate on. So go and say, hello, I'm part of your medical team. I'll be in the operating room assisting. It's important, and it's part of being a doctor. And then be helpful. So in the operating room, offer to help put the catheter in or position the patient or whatever needs to be done in the beginning. Just offer to help, because that shows that you're engaged and you're interested. And even though nowadays people are looking on their phone a lot to study, it still doesn't look like you're involved when you're looking at your phone. So try to be involved and present. Introduce yourself to everyone in the OR, every single person. So go say hello to the scrub tech, the nurse circulating, the anesthesiologist. Just tell people who you are so that they know who you are, they can remember who you are, and they can tell you what your role is during that particular operation. And don't ever make up answers. You can take an educated guess if you have an idea, but if you have no idea whatsoever, it's more important to say, I don't know, and I'm willing to look it up, or I can come back and let you know next time. And that way you're taking the initiative to say like, okay, I don't know something, but I'm going to go learn it. And then ask questions. Surgery is it's a contact sport. It can be very unpredictable at times, and we can get really stressed out as the surgeon. We are not only doing the operation, we're teaching residents, we are managing any complications that arise. We might be really focused on a particular part of the operation. And so in high stakes moments, that's not the right time to ask a question, but there are times when you'll see that everyone's just chatting and carefree, like we're closing the incision or we're doing a very straightforward operation. That's a great time to ask questions that you have. So a urologist, and urology came to me because I specifically liked surgery, and I didn't expect to like surgery. I thought I was going to be a cardiologist or a gastroenterologist and do medicine, but I actually hated medicine and found that I really enjoyed the instant gratification of being a surgeon and doing an operation and fixing a problem for a patient. So urology specifically is the study of the genitourinary tract, both the medical and surgical parts of it. And while the kidney itself, the medical study of the kidney is designated nephrologist, the plumbing of the kidney and the ureters, the tubes that drain the kidney, as well as the bladder, which are shown here, those are part of our domain, as well as the genitals of the male, as well as the pelvic floor and of the female. So we deal with a lot of different things in urology. And I think what drew me to urology was really the diversity of what we have to offer. So we do robotic surgery. Actually, the first case I saw in urology was a robotic case. I was actually not even on the urology rotation. I was hanging out in the scrub area, and I was kind of looking lost because I didn't have anything to do. We had just finished a case, and I was just hanging out, and one of the residents said, hey, come on into our room, come on and see what we're doing. And they were doing a robotic case, and I was like, wow, this is so cool. And I had never even thought about urology. And so, that was really exciting. They were at the forefront at that time of doing robotic surgery. There was very few people using the robots. We also do endoscopic cases. So here, this is a ureteroscope right here, and this is used to look up the ureter to break up kidney stones and do diagnostic ureteroscopy. And then this is a cystoscope where we look in the bladder for a number of things. And you can do a lot of procedures through a cystoscope, such as biopsies, injecting Botox, laser of stones and things like that. So it's really kind of cool that you can do a surgery without actually making any incision at all. And then we can do major open surgery. This is actually one of my cases, a reconstructive case where we reconnected the kidney to the bladder using a piece of ileum. But we also do big major oncologic surgeries like taking out bladders and replacing them and making new bladders for patients using their intestine. Or, we can do big what's called retroperitoneal lymph node dissections, where we go and take all the lymph nodes near the aorta and vena cava out. And so you can have these really big open cases, big minimally invasive cases, and small cases that you can do in the operating room and in clinic. And there's a number of different specialties of urology that you will see that we do. And we do things, as I mentioned, minimally invasive urology. We also do urologic oncology, which can be kidney cancer, prostate cancer, bladder cancer, and penile cancer. And so there's a lot of things that can be done there. We do male infertility. We do genitourinary reconstruction, which can include like putting implants in for erectile dysfunction, doing transgender surgeries in some cases, doing urethral surgeries. We do male and female sexual dysfunction. So both erectile dysfunction, low libido, low testosterone, or orgasmic dysfunction. We do pediatric urology. In fact, there's a lot of urology in the pediatric population for kids who have neurogenic bladders, who are born with congenital abnormalities of their ureters. And of their urethras. We also do endourology or stone disease. So we can use all these minimally invasive tools I showed you earlier to take care of stones. And then I do female pelvic medicine and reconstructive surgery, which includes a lot of different things. It includes taking care of bladder function in patients who have normal bladders and patients who have bladders affected by neurologic disease. Also, issues with incontinence or difficulty voiding, pelvic organ prolapse, and lots of just lots of different things essentially in the female pelvic world. And I do take care of men as well with similar problems, avoiding dysfunction. So the last thing I will say about urology is I found my tribe in urology. I found that urologists were super smart, super innovative, just great fun to be around. We always joke, like, how seriously can you take yourself when you're dealing with genitalia all day? So we're just kind of a fun group. And this is some pictures from my residency, which I'll talk about next, but this is where we ran a half marathon. We do it every year in our residency. And this is the year I ran it. And then this is us at a conference. This was last year. This is the last conference before COVID that I went to. And these are graduates from our residency from multiple years. And so we still get together, and these people didn't even train with me, but we're friends because we came from a different place, from a similar place. And we have shared bonds from just training at the same place. So then I matched in urology residency, and the residency process at this time is a match. And so I matched there, and it was an amazing experience. I got to work. Urology is tendency a small residencies. They range anywhere from 1 resident a year to 5 residents a year. And we had 3 in our residency. And urology residency, because it's so small, is very rigorous. So I try to tell people in medical school, they get really stressed out about like what residency is going to be like, but residency is a really small part of your life. And whether it's 3 years of medical residency and then 4 years of a fellowship versus 5 years of a surgical residency and 2 years of a fellowship, at the end of the day, you're doing a 7 years worth of training. So you got to think about it in the totality of what you want in your life. If you want to be a subspecialist, you're going to spend 5 to 7 years getting that training, whether it's through a surgical residency or a non-surgical residency. And urology residency is rigorous. So the first 2 or 3 years, you are a junior resident and you do a lot of grunt work. You do a lot of endoscopic cases. You take care of patients on the floor and in clinic. And you have late nights and long hours, but you get through it. I was married during my first year of residency and I barely saw my husband, and it was a struggle, but we got through that. And then I had a research year during my residency. Not every residency has that. And then I had a baby during that time. And then during your chief years, you operate a lot, and you learn a lot of surgical skills during that time. It's a really exciting and fun time. And you spend a lot of time doing those things, a lot of time in the OR, really becoming the best surgeon you can be. And I think that as a chief, when you finally reach that point, you're probably the best surgeon you're ever going to be because you're just doing so much of it every single day. And so during residency, as a woman, you face certain challenges. I did get pregnant during residency, actually twice. I had my first child during my research year, and my second pregnancy was during my chief year, and I had the baby right after I graduated. In fact, the day after graduation, I delivered. So it is possible to have a family during residency. I have a very supportive partner who is able to pick up and drop off my children to daycare, and parents who were able to come and help me. But if I didn't have that, you can hire that. And so those are things that are necessary to have a family during training. I think no matter what training you do, whether it's surgical or non-surgical, but it is absolutely possible. And then I met many amazing women in urology, and these are a few of them. This picture in the middle is my residents, actually, who are both now graduated. And these are during my fellowship, the women I worked with. But it was, I find that in urology, at least, there are only 10% of women in urology. And I tell everyone that we are few but mighty. And I found amazing sponsors and mentors and friends through this process, and it's really been amazing. So even though there are not a lot of women in urology, I think that it is still an amazing time to be a urologist, and there is a need for women in urology because we offer a lot and we have a different approach to medicine. And then I went on to fellowship. And so, yes, urology residency was tough. Fellowship was lovely. I really enjoyed that time. I got to become very close friends with my mentors and colleagues with them now. I call them all the time, and I still feel very close with them. You get to do what you really want to do for that 2 years. And it's at least in urology, an easier pace than residency. Whereas in some of the medicine fields, it can be opposite, whereas fellowship is more rigorous than residency training. But for us, fellowship is a time that we are giving to do something that we enjoy, whereas we could go out and practice and certainly make a lot more income and still do great things, because generally urology is a lot of fun and you can do a lot of fun things. So you don't need to do a fellowship in any case to go out and practice. And so this is, I graduated fellowship and went on to become an attending, and my days are very variable. This is an example of kind of 3 different operating room days. This is me doing a big, long open case. I don't remember how many hours this was, but it was very, very long. I did it with a co-surgeon and took a long time, and it was a lot of fun. And then here I am teaching residents, and you can see I'm not scrubbed in. I'm teaching and watching them. And this is before COVID, because none of us are wearing masks. And so that's one example, and they're doing an endoscopic case here. And then here I'm doing a minimally invasive case with a junior resident, and that was a quick, 1 hour surgery. So in the operating room, where I'm typically there 1 to 2 times a week, I'm doing a variety of different things. And then I have clinic 1 to 2 days a week where I'm seeing patients and doing procedures, which can include any of these, small procedures. And then I'm also teaching. So today I'm teaching medical students after I finish this lecture, and I do residence education, I do grand rounds, and I do research. So I do research in social media, medical misinformation, health literacy, and on pelvic floor disorders, which is my specialty. So that is kind of my week, and it can be very diverse. I can do, once a month, I'll do a long case that lasts me like 6 to 8 hours. And then other days I'll do 4 small cases. So it's fun in the way that, there's a lot of different things going on, and it's not, and it's actually really enjoyable. So I have to say that I'm very happy. I love teaching residents. I love my job. I love being a urologist, and I would have not picked, I'm sure I would have been happy in any specialty, but I'm very, very happy as a urologist. So you can find out more about me. I'm on Instagram, I'm on Twitter, I'm on YouTube. I also run the South Asian Wellness YouTube channel, and I'm the founder of South Asian Docs, where we try to educate the South Asian community on medical issues that are applicable to them. But of course, the education is helpful for anybody who's interested. So I'm happy to take any questions.
All right. Well, first, Dr. Malik, I'd like to thank you so much. That was a great presentation. It gives us a really good idea of your journey through urology. For those of you following along in the chat, make sure to ask any questions if you have any. We have some prepared, though. So during your journey through med school, residency, and fellowship, obviously you had different kind of workloads than you have right now. And you had different responsibilities, so far and so forth. Do you miss any aspects of your training careers, or are you just kind of glad to have that over with and now that you're an attending physician?
Yeah, I miss the camaraderie. I mean, when my residents are family, like it's, you're not going to get along with everybody in the way that you would with your friends that you choose, but they become family. Like we see each other, once a year at our national conference, and it's like we didn't skip a beat. We kind of fall back into it, and we go through this shared experience, and you really become close. So you don't get that as much once you're an attending. You get your colleagues that you interact with, and they are my friends as well, but it's not the same because you're not together all the time, operating together, getting through difficult cases or managing difficult patients together, because that is really a lot of time that you spend together.
It's interesting. Well, that's good. You get to catch up with them once a year and stay up to date with your residency friends. And now that you're an attending, what are you looking forward to for the rest of your career? What kind of things are you looking to do in the future?
Yeah, so I'm not one of those people who ever has a plan. I've never been one of those people. I kind of take things as they come. I never expected to get really involved in social media and do all these things, but it kind of fell into it, and I've enjoyed it. So I've gone with it, and who knows what the next 10 years or 20 years will hold for me. But right now I'm really happy and content teaching and being involved in the medical school and teaching residents and taking care of my patients at an academic medical center. And so I have no plans to change that for right now.
Great. Well, it sounds like you like just going with the flow and seeing where life takes you. Did you expect to be teaching when you were looking for an attending position, or is that again something that just kind of happened?
Yeah, so when you do a fellowship, you think about, should I go into an academic position where you're teaching? And I thought I wanted to, but I didn't ever know until I got down to the job hunt. I interviewed at academic and non-academic places, and I just really wanted that opportunity to teach and do research and have kind of this variety in my day to day. And that was important to me. So I took that chance, and I've been very happy with it. But I think with everything, you feel like it's a big decision, like you have to make the right decision right that time. But there's many people I've known throughout my time as a resident, as a fellow, as an attending, where they've changed jobs very quickly within the first year, where they've changed specialties in residency at some point. And so it's not uncommon, and it's not the end of the world if you make the wrong decision, but you kind of make a decision that you think is right for you and go with it. And if you don't like it, just have the guts to get out of it.
Great. So I know you touched on this a little bit earlier. You said you were debating between ENT and urology. It looks like you're happy with your decision. What kind of factors went into your decision when you were looking to match for a residency?
Yeah, so I think, so you mean the match process after I decided urology?
Yes.
Yeah.
Please.
So for me, I was getting married at the time, and my husband is a New Yorker and wanted to stay in New York and wanted to be in a big city. So we looked at programs specifically in large cities, and then I remember having like spreadsheets of like how many residents do they have, what kind of things do they offer residents, like perks, and what kind of educational plans do they have, like how many grand rounds do they do, or educational things. And at the end of the day, none of that really matters because all the residencies are pretty excellent. And I ended up matching where I enjoyed my time there. When I interviewed, like I really liked the residents, I clicked with the attendings, and I realize now in hindsight how important that really is, because urology is so small, you really need to get along with your co-residents, and you really need to work well with the attendings you're going to work with. So even within urology, there's a fit that you need to find. And when you find it, it's great. And if you end up somewhere where you don't fit in or you don't like those people, you will be really unhappy during that time, because you will be well trained everywhere. Ultimately, if you want to do something very specialized, you'll do a fellowship. But if you don't, you'll be well trained to do urology in every residency you go to, and is particularly in things like urology, where it's very competitive because all the programs are quite good. So for me, I think I would say now in hindsight that fit is much more important. But back then I was like, oh, are they doing open cases? Are they doing laparoscopic cases? Are they doing robotic cases? I had a lot of factors that went into it. But ultimately you have to feel like whatever your goal is, whether it's to be in a big city, to be with residents you like, to come out being really well trained, that you feel like you're going to get that at those places. And then you just, you kind of go with your gut.
Awesome. So you told us that you're currently teaching, seeing patients operating and also conducting research. So when did you start conducting research, and what field are you looking into?
So, I did research throughout residency and fellowship. And I did some in medical school. You kind of start getting involved in research as a medical student, if you are interested in it. And you just learn from your mentors up until you become an attending, because you're really filling the void with them, with what their interests are and what their expertise are in research. And you're trying to learn from them and do projects that interest you and work with them. And then finally, once I became an attending, I had some ideas about what I really wanted to do. And you just start doing them and learning along the way. I didn't have any formal training on like how to make a research team or do those sorts of things, but there are resources available to you once you start. And you just you find your interests, and you've learned throughout the way how to do research, and then you start your own projects.
Sounds exciting. And now you mentioned that you kind of figured out you wanted to do urology when you walked in on that robotic surgery. You said they were on the leading edge of the field, and it seems like it's a very rapidly evolving field with lots of different techniques. So how do you, now that you're an attending, how do you keep up with these techniques now that you're not really receiving any training from anyone?
Yeah, so you're always learning. You're literally always learning. So I still call my colleagues or watch videos if I'm trying something new. But very often, if I'm trying something new, I will call someone who's done it. So I'll be like, hey, let me get in touch with this person who's done this surgery and talk me through how you did it. And then you do it. Or you learn from your colleagues. So when I started, I worked with one of my colleagues who does something that I wanted to learn. And so I learned from him. Or you travel and you go meet somebody. I mean, pre-COVID, you would travel and go work with someone who's doing that surgery and watch them do it and learn how to do it. So there are certainly ways to continue to push the envelope and evolve and learn. And learning does not stop with residency or fellowship. I am constantly learning new things, and I enjoy it.
Great. And now shifting focus a little bit to your pre-med self. You said for a moment you weren't really sure if you wanted to pursue medicine, but ended up kind of doing it anyways, and it worked out pretty nicely. Was there a specific moment that you remember, or something that happened that kind of clicked and you were like, this is where I need to be?
Yeah, so I always thought I would go into medicine, but I wanted to make sure that I gave myself an opportunity to see something outside of medicine, because I don't want to just go blindly in. I mean, everyone tells you, I'm sure you guys have heard it too, oh, don't go into medicine. It's horrible. There's so much regulation and blah, blah, blah. So everyone was still saying those things back then, because there's plenty of people who are unhappy, right? In any field. I think that no matter what you do, they're going to say, oh, this is not great about this, or this is not great about that. And so I wanted to be sure that I was going to commit my life to something that was going to be so many years of training where you're making very little money. And, is this going to be worth it? So I tried to, look at other things, and ultimately decided that nothing gave me that much excitement or joy. And so I said, I'm still going to pursue medicine, which was my original plan.
Great. And now you mentioned this a couple of times during presentation, but obviously you're a woman in urology, and people associate urology with sort of a male-dominated field. So how would you advise female undergraduate students or medical students looking to pursue a career in urology? What kind of things should they do to be as successful as you are?
Yeah, so I will say that the large majority of my mentors in training were men. And that's okay. I don't think you need to have female mentorship to be successful. You will find plenty of men. In fact, the men who are my mentors and friends will still to this day call people for me and put my name in for things and really advocate for me because they care about me and want me to succeed. And so it doesn't have to be that you have to have female mentors, but it is wonderful to have them. So reach out within your community to women in, doesn't have to be in urology, in surgery, in medicine. And we love mentoring people. I mean, this is why I do things like this. I love mentoring students and talking with them and being a source of inspiration for them, because it's important. It's important to see people like yourself and see that they can do it. And it gives you the gumption to do it yourself.
Right. So you hear this all the time about how medicine is, it's really important to have a mentor or a role model, someone to look up to for advice. How do you kind of pick a mentor, or how does that happen? How does that process kind of?
That's a great, I think that's kind of a foolish thing to tell people. You need a mentor. You're going to need many mentors. I don't just have one. I have many. And some of them will be your friends or your same age colleagues or a couple years above you. And some of them will be attendings who've been in practice for 20 years. And some of them will be mid-career. And you will get different things from different people. So I've never really formally sought out a mentor. I certainly have gotten assigned a mentor, like in the Association of Women Surgeons, I have a mentor. She's amazing. She's been so helpful. But I never otherwise like went up to somebody like, will you be my mentor? And none of those students ever asked me to be their mentor. You just become, you meet, you say, I want to work with you on something, or I'd love to chat with you about something. And if that person is open to giving you their time and their attention, you see what you can get from them. And it's a reciprocal thing. Like, I'm going to, be your, learn from you, and I'm going to help you with XYZ, and you're going to help me with this. It's not something that you talk about, but generally speaking, it's a partnership that you're giving them something, like, even if it's just telling them like, hey, thank you, because of your support, I got an interview at this place, or, that's what brings us joy, right? Seeing you guys succeed. So it's a give and take, but it's really worth it in the long run to just try to make those introductions and meet people. And you will find people who end up being mentors that you never expected to be. Like the people who are my mentors now, I never thought that they were the ones that were going to be my proponents in urology, but they are, and they're wonderful.
Right. I think a lot of people might enter the medical field with a lot of pressure, or maybe they feel a little bit intimidated walking around, especially as like a med student or a junior resident. All these people going around knowing so much more than you do, and you're just now learning. And as a resident, you do multiple rotations, right? Or was your whole training specifically in urology?
So we do rotations within urology. As an intern, you'll be on, typically for urology, you'll do general surgery internships. So during that time, you'll do multiple different rotations in like plastic surgery, colorectal surgery, transplant surgery, thoracic, all different, depends on where you go. But essentially you'll do a number of different rotations during that time. And then once you're in urology, typically you'll have rotations that are urology specific, and it depends on which program you go to, but you'll be in different locations, so different hospitals, but you'll still be on the urology service, or you'll be doing a pediatric urology rotation, or you'll be doing typically clinic and OR are intermixed in urology. So, you'll have some clinic days and some OR time. So it's just variable, but yes, you are pretty much doing urology, or within urology, you may have subspecialty rotations. Like I did an infertility rotation and things like that. So it's usually what that 4 years after the intern year is all urology.
Okay, interesting. And so within the field of urology, you said there's plenty of different subspecialties you can go into. What kind of pushed you towards the female pelvic reconstructive and all the other special things you specialize in?
Yeah, I had a really great mentor in residency who does genital urinary reconstruction, both male and female. And I worked with him a lot, and I got to have a lot of autonomy during that time. And I really enjoyed the idea of having something be not ever so clear cut. Like every case was unique and had a different approach to it, and had a different treatment plan. And so I liked that thought process that went into it. Whereas something like oncology is like these are the steps steps you follow, and these are the steps you take, and these are the surgeries you do, and that's it. And some people really like that and get a lot of excitement about doing that. And I did a ton of oncology during my residency, but didn't find that as much enjoyable. And so I knew I wanted to do some sort of reconstruction. And then within reconstruction, there's male recon, there's female recon, and there's pediatric urology. And then within male and female, I decided to do the female reconstruction because I knew as a woman I would get more female patients. And now in practice, I do both female and male reconstruction because I did a lot of male recon in residency. And I do go and rotate with the male reconstructive attending during my fellowship as well. So your practice may be very different from what you choose to specialize in, or may incorporate multiple, like I do general urology. I take care of kidney stones and all sorts of things as well. So my practice is not a pure FPMRS or female pelvic medicine practice. And I like that. But some people want that. They just want to see female patients and do that specific subspecialty all day long. And that's fine too.
So it's great to have variety in your day and your patient base. Now, obviously different patients have different needs. Are there any times where you see a patient and you need to consult with another specialty or a specialty you work with closely, where you will kind of work together on different cases?
Yeah, for sure. There's very often that we do consult with other specialties. The most common ones that I consult with are colorectal surgery, because we often work together on complex reconstructions. If someone has radiated bowel or has a very challenging abdomen, I'll have them help me with obtaining the bowel segment, or we'll do like certain abdominal fistulas together. And then I work often with plastic surgery because we do a lot of reconstructions, and sometimes plastics will help us with getting some flaps or help us with the reconstruction. So those are the two that I work with most. And during my fellowship, in fact, I did rotate with colorectal surgery, and we rotated with pelvic floor, PM&R, which we had at our fellowship. So you do end up, if you have those types of people in your where you end up working, you can work closely with them.
Okay. And now when the whole world kind of pivoted to this virtual format, it's very difficult to do surgery virtually. So how did you and your practice and your peers navigate that change? And how do you take any precautions? Did you have to take a break on surgery for a little bit? How did you guys navigate that?
Yeah, so we had to, during the height of the pandemic, we canceled elective surgeries, which meant a lot of my practice was very calm. But there are certainly many emergencies in urology and many things that need to continue. So a lot of cancer surgeries, there's data to suggest that if you delay for even 3 months, that they're going to have worse outcomes and poor survival. So those things continued. I don't do cancer surgery anymore, so though I didn't do those, but kidney stones are still infectious risk. And then there's tons of, there's emergencies in urology that can be such as obstruction of the ureter. So we have to do stents for those. And, of course, genital like torsion and penile fractures and things like that still came in that we had to do. So I was still operating, but just not as much as I was. And now we're back to doing some more elective cases. And it just, we're taking it a day at a time to see what the hospital's looking like, what the needs are, and we will, we just have to be flexible.
So it's good you guys are getting back into the swing of things. Now, throughout your entire career, do you have a specific case that stands out in mind that was extraordinarily complex or interesting, or something that is kind of like stands out in your head as you look past on your years of training?
Yeah, I mean, so many. There's not just one. I've in residency, we did a lot of very complex reconstructive cases. I remember one specifically where me and my co-chief resident spent an entire day reconstructing this man's ureter after radiation. And then as an attending, I've done some very complex reconstructions with ureteral reconstruction and urethral reconstruction. And those are always really fun and rewarding and challenging. But then I also love the small cases I do where I'll do a quick like bladder pacemaker type surgery and the patient's life is transformed because they can sleep and not wake up at night and they're not running to the bathroom all day. So I don't feel like there's one case that's better than the other because the outcomes being good, it's it's all that matters, right? Getting the patient their quality of life back is so meaningful and so exciting that every case is exciting for me.
And now shifting back a little bit to your fields of research, could you talk a little bit more about how your research has affected your medical career or how it's changed your perspective on different things?
Yeah, so I think that research is the way that we can make change, right? If you have evidence behind things that you can continually show that, hey, there are these problems and find ways to improve them, that's the way you're going to do it. So that's the exciting part about research for me. So I've done recently a lot of research on health misinformation, and I find it like shocking to see what kind of stuff is out there. And so I know that that's a big problem, and we're kind of deleting that and making it more visible to everybody around us by publishing about it and talking about it. But we really need to make change. Like they have obviously now Twitter's doing like, hey, this is fake news or this is not real. But there needs to be more than that. There needs to be, with COVID, it was kind of put at the forefront, like there, you need to check the CDC website and you need to not rely on, social media sources, right? But I think there needs to be more of that. And so I think it's exciting to be a part of that thought process and coming up with ideas. But research is a long process and you have to be committed to it. And it won't be like you find an answer within a year or two. It's going to take several years. So it's a commitment, and sometimes it can be really exciting and sometimes it can be really soul crushing when you work really hard on something and nobody wants to publish it or nobody really reads it. So you just have to be ready for the ups and downs in a research career. But I think ultimately it's patience is a virtue in research.
And I'm sure you have a lot of material to look over now with the whole COVID situation. There's so much misinformation out there. Like you said, it's really important to get to the right sources, CDC website, peer-reviewed research, and not rely on tweets. Now, an important part of a career in medicine is a work-life balance, or else you're just going to burn out. So how would you describe your work-life balance, and what are some activities or hobbies that you have to kind of decompress at the end of the day, or something that you do outside of medicine?
Yeah, so I think I have a pretty good work-life balance. I will say before I started YouTube, it was much better. But since I started a YouTube channel, that's added into my work life part. But I'm learning now how to get a little more free time and kind of prioritizing my free time. So what I do and I found to be really helpful is I kind of plan out what I'm going to do in 15-minute increments in time that I do have. And I try to stick to it. And then when I am done with my day, even though there's like, I have probably 100 emails I need to read right now and like so much stuff that I could be doing, there's always going to be stuff that I could be doing. But if, I just say, I'm shutting down my computer and I'm going to be present with my children, hang out with them, hang out with my husband, even though I have all these other things to do, because they will get done. They will get done the next time I have free time. And of course, if there's a priority, like I have a talk coming up or I have an abstract deadline, like that's going to become a priority. I'm going to make sure it gets done, and it may come into my lifetime that day. But it's just making it so that it doesn't happen every single day is really important. As far as hobbies, of course, I'm a mom, so I spend a lot of time with my kids, but I like to spin. So I have a Peloton. I do that. I love to read. So I try to read a little bit before bedtime every night. And yeah, I'm really into like self-development and personal growth. So I like read a lot about that. I'm kind of a nerd, but, but it's, that's what I do for fun.
So what made you start your YouTube channel and kind of grow your audience, and what kind of things, what kind of people should be looking on your YouTube channel?
Yeah, so I, as I mentioned, I'm interested in health literacy. That's how it all started. I really am passionate about making sure that patients understand what they're getting into. So in my line of work, it's a lot of quality of life things, but every surgery and every treatment has side effects. And so if as a patient, you don't understand those things and you happen to have one of them, that can make you really discouraged, make you really unhappy, make you not like me, make you not believe in medicine. And so at the base and root of it all, I can do a perfect surgery, right? Everything can be perfect. But if you are not happy with the expected outcome, then it doesn't matter. So I had an interest in health literacy as a researcher, but I realized, as I said earlier, patience is a virtue. It's going to take many years before I can come up with an evidence-based way to educate better and then disseminate that through medical field and say, this is the way we should educate and this is better. And so I said, why don't I just try and make a YouTube channel and see if I can educate on urologic disease? And it's been amazing. I had no idea that my reach would be what it is, and also that there are so many countries that get really poor sexual education, and so many things that people have questions about and that people stress about that are really simple and easy to us, but like these are things that they have questions about. So it's been really nice to educate people. I think anyone who's interested in learning about urology, about urologic conditions, have questions about how things work in their urinary tract or genital urinary tract, like that, come check out my channel. I try to answer lots of these common questions and try to do it in a fun and interesting way.
That's great. Well, I hope everyone goes out and looks at your YouTube channel, because it sounds like you have a lot to say and a lot to inform. Now, going back to a little bit earlier, you said you set your work time and you set your lifetime. And would you say it is, as a younger student who's training or who's developing or reaching to become a doctor, would setting those hard limits limit your professional growth, or are those important to keeping a long-term run?
So you need to have rest time. You need to have time to recuperate. It may not be as much as I don't mean it that this is work time, this is lifetime. It's always work and always life, right? Like things will come up in the evenings and during the daytime that are from both parts of life. So I don't want you guys to think like it's like, okay, I'm done. I try to be done, right? But it doesn't always happen that way. But as a trainee and medical student and resident, I mean, I wasn't great. I didn't have this structure in my life, but I always made time to hang out with my friends or do things that rejuvenated me. And it was so important. Like I wouldn't have survived. I was not one of those people who could like study 12 hours a day, go to sleep and start over again. Like I needed that time to rejuvenate. And for everyone, it's different. For me, it was hanging out with friends and doing things with them. And for other people, it's going for a walk or reading a book or whatever. And so I think it's important to schedule that into your life as much as you can. You know, you still have to do everything else, but you will perform better and you will learn better if you prioritize your sleep and your well-being. And it's hard to understand when you're a trainee. I'm just starting to really understand how valuable sleep is and how little I had for so many years, and trying to prioritize it, which is still very hard. But those things are super important.
Great. And now part of your health literacy channel is making sure that patients know what their procedure is going to look like, what the recovery looks like. So what kind of techniques or ideas or things do you tell your patients before they go into surgery so that they know exactly what's going to happen?
Yeah, I mean, every surgery is different, right? But I tell them, you know, generally speaking, this is how much pain the average person will expect, what your activities will be like afterwards. A lot of my surgeries, even if they're bigger cases, the large majority of patients will go home pretty quickly and they'll feel pretty good, but they still need to have weight restrictions and not do heavy lifting and kind of take it easy. In today's society, a lot of people are ready to like go up and go and start going back to their normal activities. But when you're doing reconstructive surgery, it's important to have that downtime so that reconstruction can heal. And so that's a big thing I tell people. And it's depending on the surgery, sometimes that recovery is much longer. If you do a big reconstructive case, I'll tell people you will not feel like yourself for 3 months, you know, and just know that that's like normal. I just saw one of my first patients who I did a big reconstruction on when I was attending, and he so happy, like the best thing he ever did in his life. But that first 3 months was really hard. And he remembers it. And he's like, yeah, I was not happy, but ultimately it was worth it. It just was that really beginning challenging time. So it's important to set expectations.
Great. Now, unfortunately, those are all the questions we had. That's all the time we have for questions. Now, one final question is, how would you recommend students keep in touch with you if they want to communicate or come to you with advice? Is there a good way for them to stay in contact?
Yeah, so send me a message on my Instagram or on my on my website, which is renamalikmd.com. You can send me a message there. Don't feel offended if I don't answer. Like I said, sometimes those emails get lost or don't, because I have other things going on, but I will try to get to you and answer your questions and be available if you have questions. But again, if you don't hear from me, send another message and hopefully I'll see it.
All right. Well, thank you so much for your time. To everyone watching along, we're going to send the link to the post quiz in the chat right now. Thank you everyone for coming. And Dr. Malik, I hope you have a great rest of the day. Thanks for coming on.
Thanks, guys.
All right. Make sure to put some time into those journal questions and fill it out to your best of your ability, guys. All right. Bye.